McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. And I welcome all of you, and I'm very grateful that you've all chosen to share this next hour with us in this virtual setting to learn more about some of the research that our guest speaker is focused on. So Dr. Rakesh Patel is truly an expert in many things and has some very creative ideas and passion for improving health professions, education, research. His dedication to this is reflected in his work collaborating with people from various backgrounds, including lifting up and showcasing the work of trainees around him. It's actually been my privilege to become close colleagues with him and perhaps even friends. His main area of research is in clinical reasoning, and I share that interest with him. So you can perhaps guess at the nature of some of our collaborations. And today he's going to be talking about something that might be a bit of a frustration for clinician educators in terms of, and patient safety advocates in terms of medical documentation. I have really learned a lot from some of the examples that he has shared with me, which has sparked some interest in innovating and seeking out some grants that we are very excited to pursue as well. He is currently faculty at the University of Nottingham and is joining us virtually for that reason, because no one really was open to the idea of flying him over. And I don't think he wanted to interrupt his schedule all that much. So we appreciate everyone else joining us virtually for this event. And I will hand the stage over to Rakesh. Thank you.
Firstly, thank you for the really kind introduction, Sandra, and generous words, and obviously invitation to present at your merit rounds. It really is a privilege and an honour for me to talk about some of the work we've been doing here in the UK, and as you say, hopefully plan to do in collaboration with friends here in Canada. My conflicts of interest comprised two partnerships, really. One with the pharmaceutical company Pfizer between 2013 and 2016, and one with a not-for-profit company called Isabel Healthcare since 2017. In both cases, I've been academic lead on some collaborative pieces of work and have not to date received any finance from either third party. However, my institutions have done. My presentation today, and certainly my perspective, is heavily framed within a UK context and my experience of working in the English NHS. And I suspect there may be parallels with a North American context, but clearly health systems are all different. And just like apples and oranges, they may both be fruit, but they are nonetheless different fruit. So I'm not really seeking to generalize my perspective or experience beyond that frame of reference, but I do hope to share it with you as part of a conversation around charting and clinical reasoning. I plan to very quickly reflect over the recent Rethink Clinical Reasoning conference, which some of the audience may have attended, and then move on to proposing that we consider charting as some evidence of clinical management reasoning in practice. I'll briefly present some of the very limited evidence around charting interventions in the literature before going on to describe an educational intervention that I was certainly involved in designing for improving the performance of trainees here in the UK. And I'll finish in good time for questions at the end and perhaps suggest opportunities for potential areas to collaborate. For me, the Rethink conference in February really opened up clinical reasoning like nothing I've seen before it over the past decade and a half or so, I think. For those of you not familiar with this conference, please look for it using a search engine, because you will find the abstracts there and they're easily accessible. And the discussion around the work of the different working groups is also available as well. I say opened up clinical reasoning because clinical reasoning has traditionally, certainly from my perspective, either been a topic that's been discussed by researchers in their labs, or it's been something that's debated about in seminar rooms, at conferences, certainly between different groups within our discipline. But suddenly, I think now you had an online conference where clinical reasoning was put along words such as social justice, technology, and health systems. And that really, I think, was important for moving the conversation into the mainstream. It was here that I met Sandra, one of the co-organizers, and I do think that you should go and watch her merit video. She is interested in clinical reasoning, and she said, and describes her expertise as in experimental design and measurement. And for me, this was also great because that was expertise that complemented my interests. And we could share experiences in ways those traditional conference spaces didn't really necessarily facilitate. And I think it's that interdisciplinarity that I really think merit fosters and encourages, where clinician, educator, researchers like myself can access those different perspectives that are, I think, necessary for advancing this field of research. And medical education is interesting because it doesn't really claim, I think, an identity of its own. I think it draws from all these different disciplines and paradigms that overlap in some areas, but do remain distinct in others. So the way I see it is that clinical reasoning is this thing in the middle, and by looking at it through these different disciplinary lenses, we can illuminate it and see with a lot more clarity some of the things that I think we struggle with and get frustrated with, as Sandra referenced. And I think getting as many people into the team interested in looking at clinical reasoning through these different lenses was a priority for me in progressing my research. So recently, I think Sandra alluded to, but we did apply for a Universitas 21 grant. And Universitas 21 is essentially a group of 28 global universities interested in internationalization and globalization, of which McMaster and Nottingham are. And it really is to network and explore ideas in a bit more depth. And one idea we both had a mutual interest in was documentation or charting. So what exactly is charting? Well, some people might understand it as the act of recording or a record of all the information about an interaction following a patient encounter. The term is clearly understood differently depending on the context, and in the UK one, it might be better understood under the term documentation. Either way, I think it represents any documentation, whether electronic or by hand, associated with the patient encounter. And for me, throughout my training, both as a medical student and a trainee, looking through hours and hours and hours and reading patient charts, I spent many a time. And I read these as an undergraduate, I read these as a postgraduate, and I read them now as a physician in practice. And vividly, I recall that when I was learning at all these different stages, I read these notes and at times tried to make sense of them, but often to no avail. Having completed my training, I now get to watch others attempt to read these notes, but also write them as well. And I often do ask myself, do they really know why they are writing what they are writing? Do they really know the purpose of what they're writing? And often it seems they don't. It seems to me they're writing in the notes to them, and what has become the norm. It's something that you have to do as a trainee. It's something you have to do because it's expected of you, and it's something that you have to do because the senior either may not have time to do it themselves, or in rare cases perceive themselves too important to do it for themselves. When I became responsible for the education and training of doctors on our ward, it really was the first opportunity to explore whether these perceptions existed. It was also an opportunity for me to role model, I think, what good charting looked like, not just in terms of output, but I think the way in which charting was undertaken as part of the normal business of the ward round, as well as between members of the team. And what I became acutely aware of as well were the challenges individuals had in just trying to write in these medical notes, especially remembering what was said if they hadn't written things down in real time, or the frequent interruptions that came their way because others believed it was okay just to disturb them mid-flow as they worked. I also started noticing more and more what they were writing. And as a more experienced doctor, I could now understand medical language. I could now make sense of these words, and I could see the way in which these words came together into statements or sentences that describe clinical presentations. I could see errors of omission, errors of commission, many of the biases reported in the literature. However, I also saw other things that had little to do with clinical reasoning per se, but more to do with, say, something like conscientiousness, incomplete entries, absent entries, missing pages, ripped pages, nothing academic, but still indirectly affecting clinical reasoning outcomes, and not necessarily described much in the literature, but a common and more common problem, and really now becoming more relevant. Relevant because clinical reasoning in the NHS and the UK healthcare context is still not a well-known term, and it's not part of the common language. People may have heard of it, they may know about it, but to know and understand it as perhaps we do in a healthcare professions education context, I'm not so sure. However, because the charting directly leads to things like prescribing and other management tasks which have a direct effect on patient care, I think there is more awareness and certainly importance given to this skill. Instead, I think in the NHS, what was understood by charting tends to be framed very much around the legal and the compliance aspects. And as the slide simply says, if it's not written down, it didn't happen. In fact, over time, I'd noticed that we'd moved from an awareness that charting and documentation were important, but not necessarily essential for capturing what happened during a care episode, to a culture now where charting, or the lack of it, was being weaponized as evidence of poor care or a threat to patient safety. And similar to what we see with other software, suddenly we had the word datix move from a name for a piece of software to now being used as a verb, where NHS staff were being datixed if they'd simply upset someone at work or not done something properly. I think this was an inflection point for me personally, because I think we had something important such as patient safety being associated with charting, but not necessarily with perhaps a full understanding of the contextual or conceptual factors necessary to make a sound judgment about these incidents. For a start, I think when it comes to charting, or the lack of it, there are at least three things one should consider when judging whether something did or didn't happen. Firstly, I think conventional or traditional charting in notes is not the only place where healthcare professionals make annotations about the care they deliver. And if we really wanted to learn a bit more about what did or didn't happen in the moment, or what someone did or didn't think, then I think we really need to look at all the other places where there's charting. So the pre-hospital care records, the referral letter from the family physician, assuming the patient comes in to attention of a hospital through a non-emergency route, or indeed the documentation going the other way, back with the patient as they move from the hospital into the community. Secondly, what about all the places where the thinking and the communication about what to write takes place? As we've said already, the trainees may not get time to write things down in the moment. And what if things did happen, or things were said, but they either didn't make it into the notes or were lost in translation? And finally, perhaps more subtle and philosophical, is remembering that not everything that's said or written down is relevant. It's perhaps sometimes something what's not said but seen, or not written and not seen, that's most important. And contextually, I think the conversation around charting is generally taking place against a backdrop of diagnostic error. And when we look at diagnostic error, there's now a growing recognition that making a diagnosis is a bit more complicated than individuals simply coming up with one. and that far more accurately, there are influences from different parts of the healthcare system, not just human, but also technological, and everything we interact with to deliver healthcare. And this isn't to say this figure is a definitive representation of how diagnostic errors happen either. And that's because I think the graphic in and of itself can become a bit reductionist. For example, the representation of the patient at the start of this process, for me, seems to communicate that they enter on the left and somehow pop out on the right, and then the work system in the middle being some sort of a production line that produces a perfect already made diagnosis each and every time. I think the Rethink conference again shone a light on the very fact that not all patients may engage with healthcare in quite the same way as others, and healthcare can be inaccessible for certain parts of our society, therefore highlighting some of the real socio-cultural factors that have been traditionally missing from the diagnostic error discourse. Which brings me to the first piece of work I want to share with you today. And that was an attempt by myself and a few colleagues to investigate in a bit more detail the influence and impact of charting on diagnostic error. The reflection over this case was triggered when Ben, who's the first author on this paper and a trainee, came across to our renal unit to follow up on a case that he was involved in whilst working on the intensive care unit. And the reason for him coming across in the first place was the fact that it was an interesting case in terms of the diagnostic challenge, and he simply wanted to follow up on the patient's progress after their discharge from the ICU. We analysed the documented interaction, each and every one, specifically using a framework for classifying diagnostic error developed by Mark Graeber in 2005. The case for those of you interested in the clinical features of presentation was that of an 18-year-old white male presenting acutely unwell with aches and pains, not eating for a few days and vomiting. A leading diagnosis of COVID-19 viral pneumonia was made alongside a differential diagnosis of bacterial pneumonia. However, it transpired over time that the actual diagnosis was one of systemic lupus erythematosus, or also known as SLE. As you can imagine, the case review was a very complicated exercise, and I've tried to represent the main findings here just on this one figure. The first thing to note that there were 70 documented interactions between the patient and staff from presentation to confirmation of the diagnosis. And across each of these interactions, we identified 89 contributions to diagnostic error, of which 70 were cognitive in nature, again, complementing what we know in the literature that nearly 3/4 or thereabouts are associated with cognitive rather than system errors. The next thing to note that across the distribution of these 70 contributions to error, they weren't even across all the 25 types described by Mark Graeber's framework, with the majority instead clustering around the headings premature closure, failure to order or follow up on an appropriate test, over-reliance on someone else's finding or opinion, inaccurate estimation of the usefulness or salience of a finding, and ineffective, incomplete or faulty history and physical exam. The second thing to note is that the majority of these errors occurred within the first 5 days following admission, with more than one type of error frequently occurring per interaction. And errors occurred irrespective of the grade of staff, so for both novices and experts alike, which is, again, we know from the literature that both are prone to making diagnostic error. The third thing to note is the variability of the potential diagnosis with each transfer of care. It was almost as if the differentials varied randomly and weren't necessarily refined progressively over time as one is taught to do or would have expected to have seen happen. It was also as if the differentials depended on which individual specialty looked after the patient, where their location was, and even varied depending on which individual within the team or specialty reviewed the patient at any one moment in time. Conceptually, it's difficult to have a conversation about charting without making some implicit or explicit reference to clinical reasoning. However, when it comes to clinical reasoning, it's worth mentioning that there's an incomplete consensus on what that specifically is, or even a definition for it. This group, who were undertaking a BME review about clinical reasoning interventions, found that when they looked through a total of 625 papers drawn from at least 18 different healthcare professions, there were 110 terms for clinical reasoning, and consensus was only possible for 74 of them. In fact, there was full team of disagreement for 20 of the terms, some of which I've presented on this slide. The second thing to note about clinical reasoning is that as a process, it would seem that there's very little, if any, consistency about the way in which it takes place across individuals. So you can have 10 clinicians look at the same case, and you'll probably get 10 different diagnoses across them. And what can happen, as it was in the case I think that we've presented, is something analogous to the elephant and the blind man fable. Individuals seeing part of the problem, believing their interpretation of the part they've seen equates to the whole truth. Therefore, when I'm teaching about clinical reasoning or the process of making a diagnosis, the issue for me is not necessarily the fact that I may be wearing a blindfold, but the fact that we don't necessarily acknowledge that there's a blindfold there in the first place. And perhaps what we should be doing when looking through some of these entries in the charts is evaluating what we read with a healthy sense of skepticism and circumspect, asking ourselves, actually, is the writer cognizant of this blindfold being there or not? And if not, identifying what needs to be done to see if there's an elephant there all along. I think the consequences of not doing so is this sense of charting being this driver for this sort of blind leading the blind phenomenon, sometimes described as sort of the bandwagon effect, until such time as someone comes along and is able to take that blindfold off and carefully re-examine, reappraise the situation and reveal the correct diagnosis before it's too late. And the case I use is, say, I typically see, because the patient, as I say, is now under my care. I saw him last week. I wish I'd grabbed a picture of him because I know I was presenting today, and he's doing well and he's healthy and his kidney function is normal. So it is a good story in that case, but sometimes it isn't. Now, it's at this point, someone asked the obvious question, how could this possibly be? Medical students in the UK spend at least 5 or more years at university. They see patients from day one. And so the fact that doctors are graduating without being able to do clinical reasoning either properly or undertaking charting properly is difficult for them to comprehend. And although there are a few models for teaching clinical reasoning, there are many more for teaching how to undertake a patient consultation. And this is one of them that's been exclusively used in a UK context for that purpose. But again, for me, it's never really felt quite right, either conceptually or contextually, for the situations I find myself in, or what I now do in my clinical practice as a renal physician. I also don't think many of these models get the scrutiny they warrant in terms of their effectiveness for actually improving the diagnostic performance of learners, and indeed supporting the charting process in practice. And let's face it, there have been no shortage of models over time. This being another one, not necessarily emerging from medicine or indeed medical education, but taking its origins from the work of Amos Tversky and Daniel Kahneman in psychology, again highlighting the value of seeking interdisciplinary highlights for making sense of phenomena we observe in our domain, but may likely have incomplete understanding of it for the reasons discussed. This model, I think, is the most artistic one I could find of them all. And I suppose in the era of infographics, this is what we should come to expect from our efforts to visually communicate conceptual models. But at least in this one now, there is some acknowledgement, as indicated by this arrow, that there is a need to investigate the role of charting better to understand clinical reasoning in practice. So I suppose it's time now we look at some charting. And in this example, we see that for some reason or other, we have the presenting complaint missing. So some of you may be looking at this image, attempting to decipher the handwriting. And assuming if you get past that, or have developed strategies for you to read medical handwriting, you'll be attempting to identify the key bits of information to make a diagnosis. For those of you who are listening to the presentation and not attempting to make a diagnosis, I've moved the slide on to this example. I've done that because these examples are not to test your clinical acumen, but to sort of illuminate what we sort of see here when we look at charting and documentation of patient encounters in practice. So in this example, we've got separate entries on separate pages from two different healthcare professionals, a dietitian and a doctor. Just glancing at the entries, you immediately get a sense that there's a difference in the volume of the words used to communicate the encounter. There's a difference in the structure used to describe that encounter. There's even a difference in the clarity of writing between the two individuals, and that's even before you get onto the content. If we do just focus on the medical entry for a moment, and that's the one on the right-hand side of the image, then it's worth focusing on the annotations around the numbers. So if we look at if we were to judge the quality of the clinical reasoning process and make some sort of judgment based on outcome at this stage, I think it's fair to say that there may be an eyebrow or two raised by those with a clinical background about the management plan, which on the face of it appears to just comprise of either repeating investigations or handing over to the morning team, despite the worrying numbers that are circled and arrowed at the time of the observation. Or charting this example, which makes reference to an urgent review undertaken at 2 in the morning, alongside observations that are again not circled with arrows, but appear to be no less reassuring to me in terms of the patient's condition. The trainee here seems to suggest that the patient in question may be describing a panic attack. However, panic attacks would, number one, usually result in a racing heart or a heightened stress response, both of which don't appear to be the case here. And number two, panic attacks would presumably be a bad dream if it were in the middle of the night, which again doesn't appear to be the case here. In any case, in the context of a hospital admission, I think it's difficult to reconcile that judgment with the observations in front of us. And again, it's difficult to look at this entry and get inspired by the charting, in my opinion. Now, having seen these three examples, you'd be perfectly justified in pointing out that what you've seen are self-selected single entries, all from different case notes, and you'd be correct. So here's an example that shows a lot more charting, and charting from a critical part of the patient's journey, the admission. And this is the one from not so long ago, April of this year to be precise. And it's in fact the example I showed Sandra during one of our many conversations following the Rethink conference, when she told me about her interest in charting and more broadly charting within Canada around a medical legal perspective. So these are the first 2 pages of the pro forma from the hospital episode. And at least the sections on this occasion appear to be filled in a bit more. The page where there is most opportunity for writing or to really explore the history is the least filled out compared to the other sections. And this could be because there's little history to chart, or because the diagnosis is so obvious it doesn't need filling out, or because of reasons we already know related to diagnostic error, right? There's either a lack of knowledge, a lack of know-how, a lack of conscientiousness around this particular task. Let's turn the page. And we see some large empty spaces. Now, what struck me most about these 2 pages were the fact that the charting suggested the reader refer to the drug chart to learn more about the prescribed medication that this patient was taking. And of course, as luck would have it, there was no drug chart available when I was reviewing the case notes. And even so, I would suggest that this individual also may not have comprehended that in the future, the drug chart's going to be separated from the charting, and sort of this instruction is a bit meaningless and has really no utility to the reader. And as we turn the page again, where the findings of the physical examination ought to be, it's similarly sparse again. Again, the observer may have their own reasons as to why this may be, and indeed what interpretation to make from all these admissions. And then on the next page, what I'm discovering more and more is this phrase, see senior review. Now, in a UK context, we're probably seeing trainees spending less and less time actually reviewing the patients, either on their own before presenting these cases to seniors, or trainees seeing less and less at all by themselves, but instead seeing them alongside their seniors, where their sole function is to scribe for them. So let's go and find the senior review. And as luck would have it, under the senior review, we get C, clerking. Now, in this example, again, the diagnosis is stated as fluid overload, which is at best a clinical state or a condition. It's a set of clinical features or a syndrome, but not necessarily a diagnosis per se. And for completeness, when you turn the page, there are no investigations documented at all here, which may not be what one would expect if we remember that on the previous page, the management plan included a kidney biopsy. So I think some questions to reflect over, not necessarily to answer now, but perhaps in a moment in the final part of my presentation. Does the quality of charting really matter? And if so, why? To what extent is charting or documentation really evidence of clinical reasoning ability? And how much of this critique is seen through clear rose-tinted glasses of hindsight? And as you think about those questions, I've attempted, as I said, to pull some evidence from the wider literature around charting. And if you do a literature search using the terms charting, clinical reasoning, and healthcare professions, and education and healthcare professions, there are few empirical studies that really investigate it against some of the sort of contextual and conceptual backdrop I presented, but 3 studies worth mentioning. The first would support the view that charting is a skill that medical students may not develop without intentional instruction by the time they graduate from university. The second one I've included here is because there's a prevailing myth that doctors' handwriting is worse than everybody else's. And this study undertaken by a certain Don Berwick and published in the BMJ would say that actually doctors' handwriting is no worse or no better than that of other healthcare professions. It did, however, show that legibility was associated with, or illegibility was, lower illegibility was associated with either being senior or in an executive position or male, which is interesting and I'm sure could consume a whole other presentation. And then finally, I'm going to pick a third study, one undertaken at McMaster in 2012-2013, and again complements what we know from education more broadly, and that is a training intervention, in this case to improve charting, is better than no training intervention at all. A training intervention for improving charting is effective when accompanied by feedback on a trainee's performance when practicing the task in front of others. And thirdly, and what was interesting about this study was that the feedback to medical students was delivered not by necessarily faculty, but trainees themselves. So let's then finally turn to what was an attempt by myself and colleagues to sort of change the quality of charting, prescribing, and other tasks that I feel are expressions of clinical reasoning ability in the workplace through the development of an educational intervention we called Effective Performance Insight for the Future, or Epiphany. So I have always loved sport, and in recent times have taken a keen interest in leadership within sport and the influence of sports psychology on performance. And perhaps the most celebrated and written about example over the past decade or so has been behind the London 2012 Olympic British cycling success and the role of Sir David Brailsford in achieving that outcome. For those unfamiliar with this example, the success story was essentially based on the principle that in terms of interventions, rather than make one thing 100% better, it was probably far more effective to make 100 things 1% better, with the cumulative impact of doing all those things actually leading to transformational improvement in the example of the Olympic Games, the huge medal haul that was celebrated above. So we sat down and identified all the best education interventions we could find and thought about bringing them into a single educational intervention, clearly of multiple parts and multifaceted, but under a single philosophy. And that was design the best educational experience we could, developing the best teacher-student relationships we could, and to deliver the best feedback we could, because in terms of effect size, that was suggested to be the best, offer the best outcome. And the aim being that learners would be better able to calibrate their self-reported evaluation of performance on task. And with ours, it was essentially any one of the tasks around prescribing, charting or other. And what we were seeing or trying to develop were the basic tenets of self-assessment, self-monitoring and self-regulated learning. We comprised of a multidisciplinary, multi-professional group of patients, healthcare professionals and healthcare professions, education staff. And that included representation from the pharmaceutical industry and pharmacists and scientists from management and the business school as well. Our challenge was to then deliver this intervention in the NHS, and that was easier said than done. For one, trainees in the early years after graduation rotated every 4 months over a 2 to 3 year training program. So we needed to think about this time period in the delivery of any of our intervention. And in terms of accountability, the education trainees receive is actually only delivered by the local hospital provider, but often organised and delivered using age-old methods, albeit in an ad hoc manner, that also needed to be considered. We wanted to radically disrupt that model and use all these new age evidence-based methods to deliver the best education we could. We wanted to work with the usual education that was delivered and really didn't want to be seen as suggesting that what colleagues were doing was either incorrect or inferior to what we were doing. We just wanted to give the trainees the best experiences they could get and wanted them, certainly in the context of simulation training, to be multiple across a placement. And that simulation at the start would be used to identify areas of strength and areas which needed improvement during the placement, and a simulation at the end to identify any learning gain, as well as identify areas in need of strengthening in the next placement. And I suppose we also wanted to video everything from the simulations, and particularly the first one, so we could use the video to stimulate reflection on action and use that as a driver for supporting behaviour change over the period of the placement. Our next challenge was to research the actual impact of the intervention and specifically investigate whether, number one, our training intervention was effective in skills development and retention over time, and number two, whether our intervention was associated with any transfer of learning into the workplace. So to find out whether the answers to these questions, we designed this first pilot feasibility study such that one group of participants received the intervention, i.e. simulation and best practice feedback, and the other group just got the simulation. And in terms of outcomes, we were particularly interested in participants applying their clinical reasoning in practice, so demonstrating both quality charting and correct prescribing as a consequence of identifying the correct diagnosis or set of clinical problems. So this fMRI imaging study published in Nature Scientific Reports in 2017 provided the stimulus for us to sort of cluster charting and prescribing together. The results suggested that from a neuroscience perspective, similar areas of the brain were being used when participants were specifically asked to correctly name the names of animals, make a diagnosis, or prescribe medication. And this observation necessarily wasn't the case when individuals got the incorrect diagnosis or struggled to record cases from memory. So here's an image of what the simulation looked like. Here's Margaret. We have permission to use her real name. She was also in the picture earlier, and she's a patient with kidney disease. She had a functioning kidney transplant at the time of taking this image, and a clear example why thought needs to go into designing these educational experiences for trainees once they get beyond a novice or intermediate stage in their expert development, and when using actors or simulated patients may have less face validity. You'll notice we place the video camera in between the IV drip fluid and all the other paraphernalia of the simulated clinical ward. And as I say, trainees were literally unaware within a few seconds of the video being there. Here's an image of the debrief participants received if allocated to the control simulation group. So remember, this feedback is given by educators in the provider units who we just briefed on the content of the simulations and the correct diagnosis and the management reasoning, and they were asked to just give feedback as they would normally do. Here's a picture of the feedback from the intervention group who got the feedback we gave. And this is where participants watch themselves back on camera. And believe you me, watching yourself make mistakes over time again and again has a very powerful effect on you. And we showed them these videos alongside their charting, which you can see in the image. And they got in-depth feedback on everything related to clinical reasoning performance, be that their problem representation, their diagnostic justification, their rationale for hypothesis generation, all the components of clinical reasoning one might expect. So again, referencing the Rethink Clinical conference again, we collaborated with patients and carer communities in delivering this intervention. So here you can see our participants were getting feedback on their clinical reasoning performance, also commented on by patients and carer communities. And that feedback was passed on as information back to the participants in the intervention groups as well. So what were the results? Well, participants who received the regular video feedback over time with their simulations improve their levels of competence in a simulated setting with respect to their charting, their clinical reasoning, and their management reasoning performance outcomes. Whereas those in the control group who got the simulations but the standard debrief did not. Now, you could again argue, why did we do the study? Why did we do the control group? But these results confirm, I think, the observation that education in and of itself can have little meaningful impact. Yes, it's an experience. Yes, they probably learned something. But in this case, perhaps not enough in terms of the what we wanted as clinical reasoning outcomes and using prescribing and charting competency as evidence. So after this pilot feasibility, we knew the education had the potential to stick over a 4-month period. But what we really wanted to investigate was, did this education intervention make real world difference to patient or workforce outcomes? And to demonstrate transfer of learning, we needed a slightly different approach to the experimental design and the data control. So in the workplace, we needed not just to prove that the charting and the prescribing was better on 2 different days over a 4-month period. We needed to demonstrate that improvement over time. And in order to do that, we needed to collect data every day for 8 months, 4 months for the control group, and 4 months for the experimental or intervention group who got the training. And that is no significant outcome. So all the charts were collected, reviewed, at the end of the day, coded each and every day for 8 months. And to demonstrate that improvement, we needed to see a change in the charting error rates per prescriber, and also show that at a patient level, individual patients seen by trainees in the experimental group were less likely to suffer harm or errors compared to those seen by doctors who had not seen the intervention. So we planned 3 studies in the workplace, each with the study design being slightly different, a variation of what's shown on the screen, and divided the population into 4 groups. Our novice controls were trainees in the first 2 years of graduation, but who had not received our Epiphany training. Our experienced controls were other medical doctors beyond their first 2 years of training who had not received the training, but worked on the same wards as the experimental groups, just to look at the environmental contextual factors and try and control for them. And within the experimental group, we split those into those who attended the simulations, got the usual feedback from the consultants, and those, so these were group 1, and those in group 2 who again got this regular debrief, video feedback, drip fit over the course of the placement. They were group 2. So what did the results show? Study 1, firstly, there are a number of things to note from the bar graph. Experimental group 2, those who got the intervention with regular feedback, appear to do better than group 1, who also received the intervention but only got immediate feedback. Secondly, experimental group 1 produced more errors per prescriber compared to novice controls, i.e. those who got nothing. So remember, this is the group who attended and got the usual debrief at the end, but didn't get the monthly one-to-one feedback. They appear to do worse than those who don't attend at all. Now, why might that be? Well, group 1 were more likely than not to have attended the simulations and felt as though they'd learnt by virtues of just being there. And that just shows, I think, the training day doesn't necessarily equate to a change in behavior. And I think what we were seeing was the sort of illusion of knowledge where they feel that they've learned, but actually by attending, they may not have. Finally, the novices compared to the experienced controls, irrespective of whether they got the training or didn't, did not in this first study outperform the experts. So in this first study, I think we demonstrated transfer of learning, but some fundamental questions. Was this a one-off or could this be replicated? If so, could it be done in another hospital altogether? And if that were the case, could the intervention be improved to make that experimental group perform a little bit better and closer to the experienced controls? So we moved hospitals to see. We traveled to another location, another provider, a different ward setting, different challenges to charting and prescribing. In this study, in terms of the training intervention, the experimental group all got the simulation and the one-to-one feedback over drip over weeks and months. We dispensed with the debrief group on this occasion, and the control group were just the experienced group of doctors beyond the first 2 years of graduation. The first thing to note is the significant volume of prescribing undertaken by the experimental group compared to their counterparts. They average at over 500 items per individual. That's significantly more than the others. So they were prescribing more error, and just by chance, they were more likely to produce error. But again, in this study, we see that the error rate per prescriber was now much closer between those who got our intervention and the experienced controls. And I think that was a significant achievement educationally, to think we have doctors in their first 2 years of graduation performing nearly as good as those with many, many years of practice. So after 2 studies, I think we demonstrated the effect of the education was retained over time. We demonstrated the education was associated with the transfer of learning, especially those who receive regular feedback over time. And I think we've demonstrated that continuous refinement and optimization of that education can lead to impact. But one question remained: could we demonstrate that patients who were seen by the trainees we'd trained were less likely to be harmed by those who hadn't been trained by us? And that could only be answered by a third and final study, which I will show you here. And as this graph shows, the experimental group produced less errors per prescriber compared to the Norris control, and by some way. But this time, and for the first time, the experimental group outperformed the experienced controls. And again, going back to the start of this journey, the inspiration that we took from sport and adopting a philosophy around making incremental marginal gains, this was extremely satisfying that the third time of repeating this study, again, and we're talking in year 3, 4 of the program, we'd finally got them performing better than the experts. But ultimately, the challenge, as any educator will tell you, is engagement. And we'll see from this case study analysis, this is the only bit of qualitative data I'll show you, is that engagement is associated with performance, and engagement matters. Both are drawn from our experimental group. So within group, we show you these 2 trainees. They both attended and both potentially had access to the regular feedback. But as you can clearly see, the low engager only attended once and didn't feel they need to attend. And on this occasion, they also got worse by the end of the rotation. Again, this sense that almost they think they know it, but they don't. They know enough to be dangerous, and I think that's really important, and a conversation for another day. So I just want to finish off by thinking about some of the future challenges and opportunities. I think certainly now, having done this for nearly 10 years, I think the challenge is sustainability, scalability, and spreading interventions, and how we do that. And I think nothing we can really do that more than the collaborations we set up. At the moment, we are spreading the concept to another region in the UK, where we are now looking at that training grade beyond 2 years, but between 3 to 5 years. And we're looking to work with medicine trainees, and again, a different clinical subspecialty with a different clinical reasoning and charting challenge. We're also working with a not-for-profit company, Isabel Healthcare, to develop a web-based platform where clinical cases can be created and completed, and the components of clinical reasoning are tested in depth. So you can really look at diagnostic justification, problem representation, differential diagnosis, and this will help with sustainability over time and geography as well. And finally, I think I'd like to just conclude by charting is one form of evidence, I think, about the application of clinical reasoning in practice. I think we do need to move beyond the correct diagnosis as the only outcome of clinical reasoning to other real world ones, such as charting and prescribing, the evaluations of these capabilities in practice. I've described one intervention, Epiphany, which takes, again, an evidence-based approach for improving clinical reasoning outcomes. But I genuinely mean this. I think that the more and more we've implemented at different provider trusts, and the more we've talked about this, the opportunities for collaboration around some of the aspects we've talked about today are endless. Thank you.
Wonderful. Thank you so much, Rakesh. I really enjoyed the storytelling throughout that. I'll just mention that you did not receive a bonus for actually showcasing some of the work at Merit, or talking about the inspiration from the Rethink conference. But if that content inspired anyone to think about collaborating with some of us here, then just put merit.mcmaster.ca into your browser, and you'll go to our website, and you can learn more about our scientists and even future events. For example, our October rounds will showcase one of our scientists, Lawrence Grierson, who's going to be talking about a recent multi-institution national collaboration to look at data ethics, data governance, and policies around sharing data. But returning to the topic of today, some of the conversations that Rakesh referred to, we had some shared frustration around this topic of diagnostic error. And a lot of the theories, models, recommendations stem from what's learned from the charts, from the documentation that's available as evidence around what happened that led to the error. And, I personally was frustrated that seemed like an inappropriate source of evidence. So we're moving into the Q&A section of this hour as we wrap up. So feel free to type your questions into the chat, or you can unmute, but I'll just get us warmed up maybe with the question to Rakesh about the possible impact of moving towards electronic medical records, whether you think that offers an additional solution to improve the quality of charting and documentation from that medical legal perspective.
Yeah, no, I think the story with this started certainly for us in a UK context around electronic prescribing, and I think some of us at the start were skeptical, mainly because of our interest with technology, and I think whenever there's a new technology, it always seems by some people to solve one solution, but we often see that whilst you fix one thing, you might break something else. And I think when I was looking at certainly some of the thoughts around charting and electronic health records, there appeared to be the start of a conversation around whether it was just copy and paste or whether there was actually some sort of synthesis that was going on, and again moving it beyond just documentation, but actually facilitating what we're trying to do, and that's, you know, diagnostic and management reasoning.
Catherine.
Yeah, hi. Thank you so much, Dr. Patel, for that presentation. Very close to my heart as a emergency physician, where there's a lot of pressure to diagnose more than anything else throughout the day. Just a comment to Sandra's question about how the EMR would affect the diagnostic biases and errors. Certainly, I noticed that there's a lot more copying and pasting, much less, you know, because it's just so easy to do. The EMR systems are sometimes designed so that you're almost encouraged to review the previous charts, like very easily can see them. So that's an advantage. But the disadvantage is then you can highlight, there's a functionality of highlighting certain passages and then very easily paste into your own notes. And I know that it can be sometimes confusing, you know, for the person that's reading the chart, whose opinion is this? Is this, you know, pasted? I mean, it's supposed to be clear, but I can see in a hurry, sometimes that's a bit of a barrier. I have just a simple question for Dr. Patel. In the simulation with the resident, with the learner, how is it exactly executed? Do you have a standardized actor that's pretending to be the patient and then give a same case every time, or how does that work?
No, and thanks for that question. So one of the things we were clear was that in order to create that authenticity, every time we went to a new hospital, we would work with the clinicians to identify suitable patients that could come in for the educational intervention. So these were real patients that were either recently discharged from the hospital and in convalescence or recovering, or patients in a surgical context waiting for operations, etc., etc. And then began a, you know, usually no more than 24-hour period of essentially mocking up the notes. So this is where working with arts and drama students to create essentially a simulation. So we'd have almost a set, we'd approached it from almost a television set or whatever, and we thought of all the props. And I think I didn't show you some of the images, but I tell you, the fun we had most was trying to create the prop of Melina. Someone got some baking soda and food color dye, but obviously you and I all know that you can't recreate the smell, right? But pretty much everything else we tried to create. So it was real fun. But one thing I would certainly, and it's close to my heart, we used real patients, and it's really difficult to simulate an arteriovenous fistula. It's really difficult to mock up a kidney transplant, as I say. And we were then, it was really easy to create the scenarios because we all had their patient notes. And again, it was more cognitively, there was less cognitive dissonance when they were then going to the computer systems trying to look up for the patient records that were obviously of real patients in that hospital, so you could see everything. So the real challenge was, how good are you at creating a simulated scenario from real patient notes versus, as I say, contrived ones where it may not be as authentic or as high fidelity as it could be. So that's essentially how we did it.
Interesting. Thank you.
Oh, go ahead, Anita.
Thanks so much for your talk. That was really interesting. And sorry if you mentioned this because my internet connection wasn't the greatest, but I know your context is mostly clinical reasoning and sort of patient charting, but I do see a lot of parallels to education in general, where, for example, I study narrative comments or written assessments of learners. So a lot of the same things you talk about apply there, where sometimes the quality of the written feedback isn't very good. There's potentially omissions or, you know, things that you're wondering about that may have been said verbally to the learner, but not actually documented. So do you see any possibility of transferring sort of the intervention you talked about to different contexts in medical education? And do you think they'd be equally as effective there?
Yeah, so I do, and I think at the AMI conference this year, those of you who attended, but it's a paper that I think is more of an urban legend, because it was a medical education paper where there was a sample of only 20 people that got published in the New England Journal. And you sort of think, wow, 20 people in the New England Journal of Medicine. And essentially they videoed the performance of surgeons and showed the surgeons the performance back on video, and the complication rates from surgery around bariatric surgery dropped. And why I think video is powerful then is essentially you're not having to necessarily come up with a narrative interpretation of what you see and dance around difficult challenges. You literally have the video of what happened and you literally hit play. And I think it is a far more powerful instructional approach than sort of trying to convince a learner. And if some learners will be fine, but and we'll all know there is a particular group of learners that no matter what you say will be resistant to any of the feedback you give them. They won't believe it, etc., etc. So it was just absolutely fascinating to use the video as a real facilitation of reflection. And almost I then had a new schema in my head where I was defining learners under good prognosis or poor prognosis, because those who really just sort of didn't want to come back for feedback because they knew there were more mistakes next time around and they were just squirming in their seats, whereas others just passively watched themselves, wantonly making mistakes. And you could just tell that learner, has a different educational feedback than someone who really is high performing, and we just need to get out of their way and we just need to support them achieve the best from that training program. So I absolutely do see their parallels in the wider education we deliver more broadly.
Thank you. Yeah, that reminiscent of what some scholars recommend in terms of analogies to sports, and replaying a game, for example, to analyze errors. I'm just going to sort of highlight some of the comments posted in the chat. So we have Adriana, who agreed with the caution around the use of electronic medical records, as learners often copy and paste notes, and sometimes creates conflicting information and confusion. And then Isabel, who pointed at a potential other challenge created in terms of her job in clerking and needing to copy information from handwritten records into an electronic system, and under time pressures, there can be errors made as they're paraphrasing the handwritten notes into an electronic system, and that may actually be where people then examine the documentation for errors. Oh, so there's a question posted from Syed. So unless Syed wants to follow up in person, but the question is, there's a conscientious attitude and professionalism of the learner and role modeling by the senior doctors, and how did that impact the quality of charting and clinical reasoning? So yeah, I think I don't know if you want to elaborate on some of the aspects of that study.
I think that is a really, really important point, because we notice that really if there's no role modeling of why charting is important or why we need a good chart entry, then you could argue what's in it for the learner to produce that. Most of these learners are doing what they feel they need to please their seniors, and we know that happens for a variety of reasons. Certainly in terms of the intervention group, we used the narratives and the structured feedback as very much a scaffold to teach them how to write properly in notes. And I think they really engaged with that as a systematic framework that everyone could use. And what was really satisfying, it then allowed us to take that diagnostic framework away from necessarily the clinician. And actually what was most satisfying was that the pharmacist was then delivering the feedback. Now that opens up a completely new educator workforce where you can give diagnostic reasoning feedback by working with what traditionally would be non-medical healthcare professionals. And that I think was a game changer, because as I say, those of us certainly within renal medicine know that our pharmacists have hugely strong diagnostic skills, because they see, and they often run their own clinics prescribing transplant medication for patients with kidney disease. So yeah, I think that role modeling is really important, because it allowed them to give them scripted scripts, illness scripts as it were, for these patients, and then when we did that systematically over time across, they once they had that scaffold, we could then withdraw and sort of talk about other more sort of sophisticated aspects of reasoning. So yeah, that role modeling is important.